promise not to interrupt you other than to start with. How about that? So it's my pleasure, everyone, to introduce Dr. Nikhil Thiruvengadam, an assistant professor of internal medicine and gastroenterology at Loma Linda University Health. And this is part of our research seminar series for Stanford Pediatric Gastroenterology. We're also now, for the first time, recording this for YouTube on our new YouTube channel. So stay tuned on YouTube. And so let me tell you more about Dr. Thiruvengadam, who received his medical training at Stanford School of Medicine. So you were here for at least 4 years. And it was very interesting to hear about Nikhil's exploits here at Stanford and where you lived and the sort of interesting ecosystem that the undergraduate students are exposed to. He completed residency at the University of Pennsylvania Health System, followed by a GI fellowship at UCSF, and then an advanced fellowship back at the University of Pennsylvania. He's a board certified, in gastroenterology. Nikhil is an advanced endoscopist, and his research focuses on real-world data in pancreaticobiliary disorders. He's authored over 60 peer-reviewed papers, mostly in this space. And one of his papers, which I'd like to highlight, in CGH, Clinical Gastroenterology and Hepatology from 2020, caught my attention because it was an elegant study that took one of our own mechanistic discoveries from our laboratory and showed that in a large single center, using the electronic health record from that single center, Nikhil found that patients who serendipitously took the calcineurin inhibitor tacrolimus were protected against post-ERCP pancreatitis. And we had for more than a decade, up to that point, been examining calcineurin signaling pathways as critical mediators of pancreatitis. And so this study served as the premise for us to take back the baton and to launch a clinical trial of tacrolimus for post-ERCP pancreatitis called the INTRO trial, which is almost in the interim analysis phase. And so I share this prime example of how scientists and physicians can work hand in glove, or maybe endoscopy glove in hand, to effectively strive towards treating GI disorders. So today, Dr. Thiruvengadam will present on the topic big data, complex data mining and predictive modeling in gastroenterology and pancreatology. I think we're going to have Nikhil present for 30 minutes, and then we'll really open it up for the rest of the time, and hopefully there'll be ample time. In the meantime, please do post your questions online on the chat, or save up your questions for after the talk for the audience here. And with that, please join me in welcoming Dr. Nikhil Thiruvengadam.
Thank you so much, Sohail, for that kind introduction and for having me here. And thank you, everyone, for listening to my talk. We'll just get the slides up. Awesome. Okay, perfect. So I'll jump right into it. I don't have any disclosures for this talk. Getting into an outline of what we'll cover potential uses for real-world data, different data sources that we can use clinically, some frameworks that are available for open source data mining, and then I'll give some examples that our group has done in leveraging real-world data as well as other groups, and then some ways that people can incorporate real-world data into their analysis or clinical research ideas. Getting into the uses of real-world data, there's been an increasing kind of spectrum of what we can do with real-world data. It really started first with natural history of diseases, looking at ICD codes, how many patients have different disorders, then kind of moved into really looking at drug utilization, drug adverse effects. Now it's moved to understanding treatment utilization and getting real-world cost data and understanding health disparities. And increasingly, it's being used to really, power machine learning and now more like artificial intelligence and deep learning models in the healthcare space. And another cool application is also the use of phase 4 studies to validate phase 3 clinical trials and look at the impact of different drugs. I'll start by just defining certain terms, just so we all are talking about the same thing. When we talk about open source, it's a decentralized model of software development where the source code is publicly accessible for anyone to use, modify, and distribute. There may be licensing terms, there may be costs for using a software repository, but anyone can potentially modify it. Open data is data that's freely available for anyone to access, use, and share without legal, technical, or social restrictions. It should be machine readable, open license, but may require attribution to whoever created the data set. When we use the word data mining, it refers to the process of discovering patterns, correlations, and trends in large data sets to transform raw data into actual information. It really started out as statistical modeling and regression modeling, but now it's really moved into machine learning as well. So getting into sources for data mining, this is really where kind of clinical science followed basic science, that it really started with omics data sets. When different funding agencies and journals started to require, publications with omics data to deposit them to repositories, we started to get larger data sets with a lot of data. Sorry, I don't want to jump forward. Regarding clinical data, the first efforts were public data sets. We'll talk about a timeline in a second, really federal or state. In terms of closed data sets, it's really started with administrative claims. Increasingly, they're EHR enriched, and they may have other data. And more recently, we have social media-based data sets as well. Getting into the timeline, which you can see here, it really started in the 1970s when we had the first cancer registries. This is when SEER was, first developed. It was based in paper records, but the idea was, can we at least have a sense of the prevalence of different cancers using things like that? Then in the 1980s, we moved to the first time where CMS made Medicare claims available, and then we started to have national surveys. The idea is if we could survey a part of the US population and using statistical techniques to weight that population, this may give us trends on the entire population of the United States. They then took that in the 90s and we started to get national claims data sets, again, using public data such as NIS, the readmission data set. And really in the last 20 years is when private data and closed data sets have really taken off. It started off in the 2000s when we had data sets like Optum and MarketScan, which we'll review. Then we moved to, not only do we have private administrative claims, but then we link them to EHR data. And then more recently, can we use patient-generated data directly from the electronic health record without needing any intermediaries to things like Cosmos as well as social media. Getting into the private data sets, I'll review this for a second because different studies will use different ones. The major four are Optum Informatics. This is basically 71 million unique patients, 7% of the US population, and is connected to all sorts of data sets, socioeconomic, vital records, social security death indices, as well as cancer registry data. Then you have MarketScan, which is also proprietary, about 80 million patients with similar linkages and contains about 8% of the US population. More recently, you have TriNetX, which is a proprietary EHR-based data set. And an interesting thing here is it has 170 million patients, but they do the analysis for you. You submit the idea, and then they provide you kind of the analytical tools and the data to analyze. One challenge is it may not have the same level of granularity as the previous two data sets we talked about. And the last one, and this is probably the most exciting one, is Epic Cosmos. And this is where Epic basically connected their backend to a SQL database so that researchers can query it and really look at granular data in real time. All these other data sets are refreshing sometimes every year, sometimes every few weeks. This is being refreshed, faster than that. It depends on your exact agreement with Epic, but it's potentially even every week, every few days that the data can be refreshed. And the size is substantial, 284 million patients. And this is right now, increasingly as more and more health systems adopt Epic, the thought is this is going to go to almost 50% of the US population at some point. Getting into challenges in medical data mining, I've kind of told you about what the data sets there are. One of the biggest challenges historically is there were lots of data sets, but there really wasn't a standard dictionary. So there wasn't uniformity in coding and dates and things like that. So what you might have is someone may define a date as the number of days, January 1st, 1960, other may use a different index date. So if you were writing analytical code, it was challenging to use it across data sets. We also know there may be duplicate data. These data sets are using health insurance claims. So one patient may have had an insurance and then moved to another one. So we may be looking at the same patient multiple times. And this may overrepresent patients, a small number of patients for rare diseases particularly. Another big challenge is that some health records systems will go to an electronic health record, but not really update what was available in paper records. A classic example is if a patient has type 2 diabetes since 1992, they then migrate to Epic in 2014. In 2015, they have their first encounter that's encoded as a new diagnosis of diabetes. And we may think that that patient has a new diagnosis when they've always had diabetes. To address this, there's really been several efforts, but the most significant one has been OHDSI's approach or a framework for open source data mining. And they came up with this kind of schema or idea for how we could do this. The idea was that the source data would be converted into a de-identified patient-level database using a common dictionary. That would facilitate large-scale analytics. The analysis results would then again use another dictionary and be stored in another kind of repository, which would facilitate comparisons, confirmatory testing, and really meta-analyses and systematic reviews, and that they would kind of serve as a coordinating center for all of this. The most significant contribution in this regard is they created something called OMOP. And the idea here was they wanted to standardize data structure, content, semantics, how you define a cohort, and then which covariates you include. And if all of this was clearly illustrated in a repository, this would allow investigators to verify results or see if a finding has changed over time. Getting to OMOP, which I described earlier, this is kind of a schema of what OMOP involves. But basically, to simplify, it's having a standard definition for different variables in a data set. So they took what are the typical variables in an EHR-enriched administrative claims data set, and how do we standardize them? And so the idea was that it could include both inpatient and outpatient settings. It's designed to support registries, longitudinal surveys, cancer data. And it really is very comprehensive of what we need for healthcare data so that it makes it easy for researchers to use. The idea for OMOP was, you start by classifying different things using source codes. I'll give you an example down here, and this is directly from their kind of publication on this. Is in the electronic health record, you may have ICD-10 codes, you may have CPT codes, you may have some SNOMED codes. You would then classify them using a SNOMED CT code, and then, have a standardized vocabulary. You could do a MedDRA for, medication-related things. You have different classifications for each part of these codes, so that what ends up is a standardized terminology for how we're talking about it. Once you code all this, then you can query it top level down and go to kind of lower level concepts and really get granularity of the data without losing that standardization. After kind of this effort, and this really started in the mid 2000s, there's been a lot of uptake of OMOP. You can see the data sets that are using it. A lot of the ones I mentioned, MarketScan, TriNetX, Optum, the All of Us research data set, which is really exciting, prospective national cohort that's collecting a lot of very interesting data, adopted this as well. But this really facilitates analysis across these data sets without the need for recoding and changing the analytical tools significantly. Next, I'll get into some examples of real-world data mining. We'll start by looking at natural history and procedure trends, and something that we did in pancreatability endoscopy. The concept here is that there's a condition called sphincter of Oddi dysfunction or sphincter of Oddi spasm. And the idea, as you may remember, is the sphincter of Oddi is a muscle that controls the opening of the bile duct and pancreatic duct. And we know that, based off natural history and some prior work, that the thought was that if you have increased pressure from the sphincter of Oddi, one, you can get pancreatitis. It's thought to be the mechanism for why people get gallstone pancreatitis. And this has been shown very nicely in animal models, including, a model that Sohail had, and looking at ductal hypertension. But we also know clinically drugs that stimulate the sphincter of Oddi cause pancreatitis. With a mu opioid agonist, the classic example that very nicely illustrated this concept. The reason the sphincter of Oddi is important is that we know that ERCP can cause sphincter of Oddi spasm, can increase ductal hypertension, and can cause pancreatitis as well. Given that, there's a disorder where the thought is that because the sphincter body is dysfunctional or spasming, people are getting abdominal pain and recurrent pancreatitis. And we call it sphincter body dysfunction. And we know the US population is a perfect setup for this condition. The hallmarks of the condition are pain paired with abnormal liver tests. It may be paired with a dilated duct as well. So if you look at the US population, gallstones are very common in up to 40 to 50% of patients. They undergo laparoscopic cholecystectomy. It's well known that as a reservoir effect after cholecystectomy that patients' ducts may dilate. And so that kind of provides one risk factor for sphincter body dysfunction. We also know there's an increasing number of causes of abnormal liver tests in the US population, mainly related to steatotic liver disease, such as alcohol and mast cell, but also to a variety of drugs. And we know that both aging and opioids contribute to duct dilatation as well. So this is a disorder that's widely prevalent, and it represents a challenge for gastroenterologists to manage. I won't get into the classification of sphincter body dysfunction, but there was a type 3 sphincter body dysfunction in the Rome 3 classification that really was chronic recurrent abdominal pain with neither abnormal liver tests or a dilated duct. We have really a very well done study called the Episode trial that was published in JAMA in 2014 that showed that compared an ERCP-based intervention to cut the sphincter body to a sham intervention. And long story short, it showed that sphincterotomy does not help the pain in people with normal ducts and near or normal laps. Based off this, prior work had used administrative claims and had found that, as I mentioned, we know the US population is a setup of SOD, that the number of diagnoses of SOD is increasing per 100,000 patients. And so they found that as the number of people who had prior cholecystectomy increased, so did SOD as well. However, they concluded that if you looked at patients who had a sphincterotomy coded for SOD, that reduced over time. And there was a dramatic reduction seen after that JAMA paper I mentioned was published, and suggesting that as a procedural problem, that this is not a problem. So we decided to tackle this using kind of a different approach rather than relying on what physicians code, using an EHR-enriched administrative claims dataset Optum, and looking at ERCP utilization overall in the post-cholecystectomy population. So we basically included patients from 2004 to 2018 who underwent cholecystectomy, and then asked how many of them have a first-time ERCP for a non-malignant indication, meaning not for pancreatic cancer, cholangiocarcinoma, or for liver transplant or other reasons. We also measured the use of MRI and EUS within 1 year of ERCP. And then we categorized ERCP into perioperative, which is that occurring around the time of cholecystectomy, early, which is a month to a year after cholecystectomy, or late, which is more than a year after cholecystectomy. The idea is that the perioperative ERCPs tend to be related to choledochlythitis or stones in the bile duct. The early ones may be a missed stone or a complication from cholecystectomy, such as a bile leak or stricture, but late ERCPs are unlikely to be an adverse event from cholecystectomy or potentially a missed stone. So, what we demonstrated compared to the findings that I showed you earlier was that using an age-adjusted incidence, so adjusting for changes in the US population, we found that late ERCP occurs in approximately 39,000 Americans. And what you can see in these graphs is in A and B, the incidence of perioperative and early ERCP really don't change over this time period. But you see the age incidence of late ERCP increase fourfold over this time period. Now, one question may be, maybe just more people have, primary choledochlythitis or a missed stone after their gallbladder is removed, but only 44% of these were actually involved stone extraction. When you look at the use of biliary imaging, this is EUS, MRCP, or IOC, you see a similar trend in that the numbers did increase, but just very slightly so for the perioperative early. But there's a dramatic increase, particularly in EUS utilization prior to the ERCP. And what this nicely demonstrated was, one, compared to what, a simple analysis of administrative claims found, ERCP utilization actually has increased dramatically, but also it's that EUS is driving more ERCP, not preventing it, as some may have thought. When we get into what happened after this late ERCP, we demonstrated that outcomes were worse. So if you look at post-ERCP pancreatitis, they had the highest rate, 7%. If you look at hospitalization, 13% were admitted to the hospital. A quarter of them needed a repeat ERCP within 3 months. And the most interesting finding is that we found about 10% of them had a new chronic opioid usage after the ERCP, and a quarter had any opioid usage after that ERCP in the next month, suggesting that rather than reducing pain, this may potentiate a pain syndrome in these patients. So what we demonstrated really nicely was a 9-fold increase in late ERCP from 2004 to 2019, a 2-fold increase in MRCP in the US during the same period, and late ERCP patients really resembled kind of functional disorders SOD. And this data was thought-provoking, but leads to a lot of questions, which is how many of these cases are primary cold locothiasis or missed cold locothiasis, and what is the benefit of ERCP in this population? This highlights that, with data mining, we can take a question that had been thought to be answered and really provide a more in-depth and nuanced answer than simply looking at administrative claims. The next example that I'll show you is one looking at pharmacoepidemiology. And this is, in this study, we chose to look at post-pancreatitis diabetes, or PPDM, which used to be called type 3C diabetes. But the idea is this is diabetes that develops as a consequence of acute or chronic pancreatitis. We know that up to 15% of patients, this includes mild patients with acute pancreatitis, will develop diabetes in the next 5 to 10 years. And there's a 2-fold higher risk of diabetes after the first episode. And this is seen really nicely in this cumulative incidence curve. There's a substantially higher risk of diabetes. A lot of mechanisms have been proposed. Is it chronic low-grade inflammation? Is it lipolysis of fat cells? Is something changing about the hormonal axis? But our question specifically was, could statins interrupt this? We know that statins have pleiotropic effects, including an anti-inflammatory effect. They've already been studied in a variety of chronic inflammatory conditions with mixed results. Regarding pancreatitis, there is some data that statins may reduce the risk of acute pancreatitis, but there's also some conflicting data where it's well described that in patients who are new onset users of statins, there may be a slight increase in type 2 diabetes risk. So our question really was, what effect does statin usage have on post-pancreatitis diabetes? And could this tell us more about the mechanisms that drive PPDM? So again, we went back to Optum, which is really the primary data set that we were using at the time. And we looked at the 71 million patients. We identified patients diagnosed with acute pancreatitis from 2008 to 2021. And we required 1 year of continuous enrollment in medical and prescription services prior to acute pancreatitis. A key thing for these studies is how we define the exposure and outcomes. We define statin usage using a pharmacy-based code. And to prevent reverse causation, we only measured statin usage prior to acute pancreatitis, meaning we didn't want a patient who presented with acute pancreatitis, had not been in care, to be diagnosed with diabetes, start a statin, and then kind of measure an association that way. We defined regular statin usage as patients who filled it for 80% of the previous year, as it's been shown to correlate with long-term usage, and then used a definition for diabetes requiring one physician claim and at least a prescription for hypoglycemic medication or insulin. One thing we were able to use here is a unique package called cohort method. We were talking about open source analytics. This is a classic example of how OMOP can really help here, in that it's designed to create a new user cohort and allow for large-scale propensity match analyses. And you can use the same command across OMOP data sets, right? So we can do the same analysis we did in MarketScan with just some tweaking of the variable names, but not requiring us to rewrite anything or recode anything. This is our flow diagram. As you can see, ultimately, we looked at about 118,000 patients. 27,000 were irregular statin users, and then we compared 82,000 non-users to 9,000 statin users. What we found, using a competing risk model that you can see here, is a cumulative incidence of new onset diabetes was substantially lower, even at 12 years of follow-up in the statin regular user arm compared to the non-user arm. We know that there's a 42% lower risk of developing PPDM in an adjusted model. And there was a similar finding even when we excluded diabetes that occurred in the first 3 months after presentation for acute pancreatitis. We showed a similar risk reduction in both mild and severe acute pancreatitis. And given the large sample size, we actually looked at both the negative control exposure and negative control outcome just to see, is this a statistically significant finding? There's a chance finding just given the large sample size that we had. And again, didn't find any association with either of those two exposures or outcomes. We demonstrated here that, there was a 42% lower risk for PPDM, and we demonstrated benefit across etiologies and severity of acute pancreatitis. This raises a lot of interesting questions, more provocative than potentially, changing clinical practice, but really, suggests more research is needed to understand the role of statins in acute pancreatitis patients, but highlights that using, large data sets, we're able to look at the non-target or non-planned effect of a medication on a different disease and outcome. Finally, I want to just briefly review kind of using large data for predictive modeling, using machine learning and AI techniques. And the reason I saved it for last is we're just starting to do this. So a lot of this is very preliminary, but it's still very exciting. I wanted to first highlight a study published by this group at eBiomedicine that looked to see, can we predict who's going to develop pancreatic ductal adenocarcinoma using EHR features such as basic demographic features, diagnostic features, medications, and lab data. And they use two approaches. One is they use a neural network-based model. The other, they use a more traditional logistic regression model. And using this, you can see here their AUC curves. They were able to demonstrate, good ability to predict PDAC with an AUC of 0.82 in their neural network model. And it was better than the logistic regression model that they studied at the same time. This was really primarily based on training data, so there's a lot more testing that needs to be done, but it showed that, this approach may work for predicting PDAC. Another group took this, and used a similar approach, this time creating an open source tool using Python, and looked at a different data set. They combined 6 million patients from Denmark with 3 million patients from the US Veterans Administration. And this again really highlights what a common data model does, right? They were able to combine disparate data sets from 2 different countries and use them both for training and testing, and again, looked at different machine learning models and were able to show, actually excellent AUC for predicting, PDAC in the next 6 to 12 months based on these clinical features. We've started working on some of this using Cosmos as well, but it's still very much in its infancy. And I hope all this research highlights that, a lot of clinical researchers can integrate both open source tools and data platforms in their research. And these are just some possible suggestions on how, one could go about that. The easiest to access for most centers is actually Cosmos, because if you have an Epic license, then you have a pathway to obtain access. It usually requires slicer dicer training and then, further training to obtain access, and requires SQL and R. In terms of other data sets, most of the public data sets, CRA, NIS, Medicare claims, are available for free or low cost, such as the Medicare CRA. The trade-off, of course, the cost is low, but they don't provide the same level of granularity as some of the private data sets. Increasingly, a lot of institutions are providing access to Trinetics, which, with their advanced analysis platform and them really taking charge of the analysis, can help you perform the analytics without necessarily coding or knowing how to do so. The last thing is there are certainly software boot camps for both R and Stata, which is oftentimes used for both of these things. And really, AI coding tools can help someone who has some understanding of it really speed up what they're doing and not have to spend as much time coding, but more kind of understand general principles. With that, I'll get to my conclusions. We know that real-world databases provide a unique source of data from multiple study designs that are oftentimes not feasible prospectively or retrospectively. They're meeting unmet needs in the clinical and research landscape, such as pharmacovigilance and understanding treatment utilization. The most exciting kind of step in this regard is really Cosmos. We're talking about 4 times as many patients as we had before, a lot of real-time granular data coming in. So this brings a host of new applications, and you'll see a lot more work in this area with deep learning and machine learning. The last thing is that many institutions offer access, including Stanford, and statistical support to help people get started and utilize this research. With that, I'd like to thank you all and take questions.
Okay, we're now open for questions. And we have ample time. Let's start with the audience here, and then we'll go back and forth with the chat. Can you introduce yourself? to all of us.
Sure. Yeah. Michael Rosen, UIVT. So, I was interested in his like a statistical sensitivity analysis question. You chose a negative control outcome and predictor, which I thought was interesting. What are the principles behind how you choose those? Yeah.
Yeah, great question. So the negative control outcome is typically an outcome that a randomized control trial has not shown a benefit for. So like, for example, like we chose hip fractures because statins have been studied for that, and there was no effects I've seen across multiple RCTs.
Okay.
Then for the negative control exposure, same concept with whatever the outcome of interest is. So like we know from lots of beta blocker based studies that they are not associated with an increased risk of diabetes. So that's kind of how you choose them. So they tend to be like older medications or something that's been studied extensively. That's unlikely to be a true signal with it. And then they're basically, if there is an association, there's just ways to then try to adjust the analyses, because it just may be a chance that we have such a large sample size and such large power, we may find statistical associations that are not actually associated.
Okay. Thank you.
Could you unshare your screen?
Sure.
And then we, at least for those who are on the Zoom, we can informal visual discussion. Please also feel free to post on the chat any other questions. I'd like to start off by saying this is really cool. This whole question about statins. You may have seen the SIMBA trial results. So, years ago from California, a lot of this is homegrown in California. Beach and Wu had identified statins in a real-world data study using Kaiser patients, and that sparked several groups to start looking at statins. We have a grant with statins with the Cedar Sinai group, and there's been probably, I don't know, something like 36 papers on statins and pancreatitis, mostly showing a benefit. But the and of course, your recent study showed that there is a reduction in post-pancreatitis diabetes mellitus. And so I guess the question I have for you is, then when you get into a clinical trial, like the one that was just published, so there's a trial published, randomized, called a triple randomized controlled trial from several sites, not too many patients, only about 85, I believe. So you could argue about the numbers, but multi-center, in which they gave statins for recurrent acute pancreatitis, it did not show a benefit in reducing the incidence of recurrent acute pancreatitis, the frequency in patients who had it. What was interesting was within the small subset, there was an increased risk of developing diabetes.
Yeah.
And it was small, but it doesn't negate the importance of the real world data. But could you help us understand how we can navigate this study and then like the multiple other studies that are out there?
Yeah, thank you, Sahil, for that question. I actually talked with Steve Pandel once we had our data, and he has obviously a lot of interest in this and was able to kind of create a placebo version of statins and package it and all that. And I think just 2 points about that study, and I think a lot of pancreatitis studies in general. I think one challenge of an outcome like next episode of acute pancreatitis, there's so many factors that go into whether a patient's hospitalized or not, whether they're home and having pain. So that's a really hard endpoint in that sense. In terms of how to kind of square it, the way I look at the real world data is I think it's hypothesis generating. There's another study, and I honestly didn't have time to highlight it here, where it was published in JAMA in 2023, but what they did is they took 15 phase 3 RCTs before they started enrollment and said plan to do the real world analysis at the same time. And then were able to demonstrate that they showed the same effect size before they knew the results of the RCT as the RCT itself. I think there's certainly some value to it, but I see it more as hypothesis generating. And one of the questions we want to see talked about is what would be the long-term effect on post-pancreatitis diabetes 5, 10 years out. Certainly there is that, and that's why we want to study. There's that known increased risk, of type 2 diabetes when you start a statin. So I'm curious what they saw, but the problem is it's such a small sample size that it's hard to make, and there were not many patients who developed diabetes, so it's hard to know, is it just, statistical chance, or is it actually, that same signal that you've seen very nicely with new statin users in general?
Very valid. Thank you. Want to ask another question, or please feel free to ask as many questions as you'd like. So there's so many opportunities, whether it's in celiac or IBD, and many of our IBD folks here embraced real world data, and in pancreas and other fields. There is a network that was created through blood and sweat, mostly sweat, called the DILI network, the Drug-Induced Liver Injury Network. And it was supported by the National Library of Medicine. It was a huge amount of time, effort, cost with manual curation. And it is a useful database. I've gone through it many times. I don't go through it that often anymore. But it's available to understand whether drugs are associated with liver disease. And then there's sort of curated, information. We could do all of this using many of the current tools of real-world data, AI agents, and empirical testing. And so, any thoughts about that?
Yeah, no, I think it's definitely a great point. I don't know if anyone has used open evidence in this room, but it's like took the same concept and what if we did it, faster using AI? And I think there's a lot of interest in that. I think probably more than the neural networks that we see for like generative AI, a lot of interest is in deep learning and how do we avoid things like the tool like falsely reporting information, right? Like so it has to have the ability to say that it doesn't know the answer, or but I think that's what real world data could provide, the like large amount of data that these tools need, similar to the internet for like language based large language models and those kinds of tools.
And specifically for a problem like pancreatitis, for example, frequency turns out to be an important factor in determining whether a drug is likely to have induced the problem or simply is associated without necessarily being causal. And for example, the thiopurines, the latency period, roughly around 3 weeks or 3 to 6 weeks. We had a case recently, asparaginase, valproic acid has a much greater latency. The beauty of some of these granular data sets, including TriNetX, which we've used for asking questions like this for one drug in particular, is that you can determine latency because the pharmacovigilance aspect of the real world data is pretty good.
Yeah.
Where we've had a lot of problems, and I wonder if you could comment on this, is ICD-10 coding. As physicians, many of us will quickly hit the button to try to code as many as we can in order to feel like it might be legitimizing all the hard work we're doing, rather than thinking about what implications it might have for someone using those data later.
Yeah.
And I feel like that's fraught with all sorts of difficulties. How do you sort out all of the noise in some of this behavioral patterns?
Yeah, it's a great question. Typically, there's a lot of work done on understanding the sensitivity and specificity of ICD codes as you described. So inpatient codes tend to be more reliable just because there's a strong financial incentive to capture the right DRG to bill for that inpatient encounter. So things like inpatient diagnoses in general have better sensitivity and specificity. But outpatient ones are very poor. Like I mentioned, if you use a definition of just a single physician claim for diabetes, the sensitivity and specificity is very poor. But that's why you try to pair it with pharmacy data and lab data, right? So you could just say if they have at least one lab-based definition for diabetes plus a medication plus a physician claim, then you increase the sensitivity and specificity. But it's a huge problem, particularly for rare diseases. Diabetes is not that big of a problem because we can keep narrowing the definition. But if you have a very rare, a rare outcome of interest, like even something as recurrent acute pancreatitis, and it's only a few thousand people, like how strict are you going to be, right? Like, do you want to separate some time between the episodes, like 6 months, 12 months, not miss just rehospitalizations and, things being coded because of a history of acute pancreatitis? So that's certainly a problem, but that's kind of why the EHR enrichment makes it really easy. So like Cosmos, now you can apply, natural language processing and look at the notes directly and not rely solely on the ICD-10 code and say, this is what they're presenting complaints for. This is what the CT scan showed. Can I incorporate all of that in it? So,
Thank you.
Yeah.
I just have a couple more questions, but again, I feel like this is maybe conversational, hopefully interesting. I can also ask offline, unless, okay, we can please identify yourself. With your identification card.
Yeah, my name is Perseus. Also, I guess to build off Michael said, do IBD. You mentioned. I was thinking of dovetailing off of your question, but you mentioned at the end where Cosmos now is able to use NLP to look at clinical notes, and so is this something where a user could, let's say, ask to have all colonoscopy reports and have Mayo scores generated off of that, and then does Cosmos do that kind of proprietarily through their own software, or does that actually come to you as the user for you to then look through and actually develop your own work?
Yeah, that's a great question. It really depends what endoscopy software you're using. I don't know if, what Stanford uses or not, but Epic has their own endoscopy software called Lumens that we just adopted at Loma Linda. And so one of the potential upsides of that is that data should be available for any researcher to look at through something like Cosmos. Right now, because the vast majority of places don't use that, a lot of endoscopy reports may be as a PDF,
Sure.
Or maybe just a text summary of it. So like endoscopy data is not a good example of like something that's easily accessible unless there was some sort of standardization that like a researcher put the Mayo score somewhere else into Epic. But that's where people are hoping that's the promise of Lumens. It's that you take endoscopy data, which has really been in a black box, and then make it just like any other data in Epic, so that people can search it and analyze it.
So it's just to follow up on that. Let's not take endoscopy data then, but just outpatient clinic note data, which should be what I would imagine, kind of across Epic. How does Cosmos? How do you utilize or leverage Cosmos's tools to kind of then look at an outcome that may be really best found in the clinic note itself?
Yeah, that's a great question. I think right now, basically, what's in the database with SQL, you don't have that level of granularity. Like they're not putting every single note in the data set just because it would be a massive size to search through. But there's certainly the possibility that could be included in the future relatively easily. They are doing it for like individual institutions. So like if you want to search all of Stanford's EHR, that's very doable. I think it's just the size of the data across Cosmos to have every single note to be able to search. That's just it would just require a lot of computational effort to do that. But it's certainly possible for like, for example, there's a UC-wide, de-identified data set that was based on Epic. You can do that. Like that's doable. So I think it just depends on the size of the data set. And some groups have done this for the VA through CPRS as well, that they've been able to search nodes and do things like that. So the concept is definitely there. I think executing it across institutions is a lot of data. And I think we haven't quite, achieved that as yet. But, this is where things like, artificial intelligence tools that, make reading, billions of web pages fairly easy could do something like that, and search through that and find what you're looking for. But that's probably like, we're not right there. We're not there as yet. But that's like the hope of something like that, is that you could do things like that. But there's a lot of interest in the endoscopy space because right now we rely on things like GI Quick, but the problem is people are voluntarily submitting their data to GI Quick. So it's obviously in your incentive to do so. So as an example, like for things like adenoma detection rate, if I had an adenoma detection rate of 0, I'm not going to then submit my data and say like, let me submit this data. So but this is not only with ADR, we find this even with the RCP, is the data tends to be very skewed towards positive findings, right? Like we did a study, then it was a really good study. That means endoscopists stopped doing something. But we like those of us who do endoscopy know that it's really hard to change endoscopic practice patterns. Like if patients want it, providers want it, like it's really unlikely that they're going to say, no, we'll stop and do it. And that's why we were really interested in doing that SOD study to see what exactly happens with endoscopy. Yeah.
That sounds great. I think we have a question from the audience online. And just before we go to Yi, can you come closer to the edge? Because I'm monitoring us and camera keeps, I think, focusing out on you.
Oh,
So now we have someone online, Dr. Yi Jiang. Would you please introduce yourself?
Yes, of course. Hi, everyone. Hi, Nikhil. Very great talk. And I am an adult pancreatologist. I'm working on the adult GI at Stanford Medicine. And I'm very interested in database research, and I've been paying attention to your research for quite a while. It's great to hear your talk again. I do wanted to ask, we come up a like research idea and we try to look into a database that fit into the study best. And I did a lot of investigation, and I find that the available databases, particularly for pancreatobiliary disease, they have their own strengths, limitation, and maybe one area fit into one database best. I wonder if you have any favorite database that you commonly use that you could share the experience, maybe which topic fits into a certain database better, and what are the limitations. Just don't go to that database for certain ideas, things like that. Thank you so much.
Awesome. Thank you so much for the question. In terms of which database we use, honestly, probably is more determined by which database we are licensed with through our institution than what we may have access to. Certain institutions may license all of them, but for example, we had Optum Informatics. Now we moved to MarketScan in terms of a licensing agreement starting this year. So certain databases may do that. In terms of the limitations, I think in terms of the most granular data, I think both Optum and MarketScan and even Cosmos provide that. Kinetics makes the analysis simplified, but there are some concerns that it may not provide as much granular data, such as exactly when a medication was started or stopped and things like that. But it obviously makes the analysis a lot easier because having to sift through a lot of pharmacy data and try to sort all this out is very time consuming. Most of the limitations tend to be more just like IC limitations. Like we just have to rely on how someone coded their ERCP. Like the assumption is they would maximally code to get the most reimbursement. But for example, there's not an ERCP code for pancreatic duct stenting versus bile duct stenting. It's just ERCP with stent placement. So like you lose granularity in questions like that. But in terms of that, because most 3 out of the 4 use OMOP, all of them use ICD-10 codes. The limitations tend to be more with the way things are coded than the databases themselves. So that's, I think, the biggest challenge.
I completely agree. I use databases for chronic pancreatitis or acute pancreatitis related research, and I realized that every time I have to write in the limitation section, the accuracy is based on ICD code, and that's like not as good. Yeah. Thank you.
No, for sure.
Great, thank you. And one plug that I put in is that in pediatrics, for example, we're really trying to promote what the department has invested in, which is a database called PEDNet. And it comprises a pediatric hospital-based EHR. And it's very powerful, and we have access to it. And we're also throwing in resources for anyone who's interested, faculty and fellows who work with faculty. And then I made this comment at one of our journal clubs. I'm increasingly reading to your point about hypothesis generation. You have to be careful. These data are great to generate hypotheses, but you can't hang your hat on them. What do you hang your hat on then is a question. I think that's all being sorted out right now, because even the clinical trials, when you're dealing with like 85 or 100 or 200 people, are not entirely clear. However, I'm increasingly reading that, like, figure one, a paper in Nature Medicine started off with the UK Biobank. It is almost indispensable for groups and clinical translational research groups not to adopt some touch point in real world data to be able to not only publish, but maybe genuinely make meaningful inferences today.
Yeah, I totally agree with that. And I think it's really useful for looking at, from adverse events associated with different pharmaceutical agents, like going your delayed comment. It's less useful for, like, as you describe, I have condition A, use drug X to treat condition, A, and then you have an improved outcome or not. Those obviously need clinical trials, but it can provide a lot of confirmatory evidence or question, results. Like, say that study had been positive, with 80 patients. Is that going to hold true if you have, 1,000 patients or 2,000 patients, or you go from having, very healthy clinical trial patients, like particularly in the oncology space, where the criteria are excluding a lot of patients who may have low performance status or lower hemoglobin or albumin. Now you take it to general population and see kind of how did this perform. So I think there's value in, like, assessing the validity of clinical trial data, but not replacing. So.
Of course. Great. Well, if there are, let me just check on the chat here. There are no more questions, and let's thank Dr. Thiruvengadam for a great talk. There's pizza. I know we had pizza 2 days ago and 12 or yesterday. We will shake it around.
Thank you.
Thank you, everyone. Thank you.
Great talk, Nikhil.
Thanks.